Dr. Dhruv?
Good afternoon. I shall present on transforming outcomes in severe VKC, multi-layered AMT approach. To introduce to the topic, severe mixed VKC can present with Horner-Tranta dots, punctate keratitis, corneal shield ulcers, limbal stem cell deficiency, and corneal neovascularization. Particularly, shield ulcers are challenging to heal and carry a high risk of secondary infection, perforation, and significant visual disability. Their pathology arises from both mechanical trauma and toxin damage. Difficulty in managing shield ulcers has prompted the use of systemic immunomodulators like cyclosporin tacrolimus, though these drugs pose potential local and systemic adverse effects. This case report stresses the importance of treating the advanced VKC and shield ulcers by understanding the underlying pathophysiology rather than routinely exposing young patients to systemic immunosuppressants and their associated risks. There is a case report of 16-year-old male patient referred to Cornea clinic about 6 months after being unsuccessfully treated at several places with chief complaint of right eye watering and DOV since 6 months. Patient was known asthmatic on treatment 6 years with no history of any ocular trauma and or surgery. At presentation, patient had right eye vision of counting finger near face and left eye best corrected visual acuity of 6/9. On anterior segment examination, patient had giant cobblestone papilla of the right eye in UPC with large shield ulcer approximately 6 mm into 5 mm with plaque covering pupillar area with gelatinous limbus with pigmentation. Left eye had small UPC papilla with gelatinous limbus and clear cornea. Posterior segment was unremarkable in both the eyes. Patient was started on aggressive medical management. As we know, preventing the allergen exposure to the ocular surface is a key element in treatment of the VKC. Frequent cold water lavage, cold compresses over eyelids, and maintaining the proper eyelid hygiene serve as the cornerstone of the effective management. Patient was started on both eyes, cromolyn sodium 4% eye drops 4 times a day, lubricating eye drops 1 hourly as it causes frequent washout of cytokines and allergens from ocular surface. Coating the ocular surface to prevent the allergen contact as well as soothe the eye to alleviate the symptoms. Patient was also started on both eyes tacrolimus eye ointment 0.03% 3 times a day. In right eye, prednisolone acetate 1% eye drop 1 hourly only until the operative procedure was undertaken approximately after 2 weeks of the presentation of patient. Moxifloxacin eye drops to prevent secondary bacterial infection. Tablet levocetirizine 5 mg, 1 tablet at night was started, and tablet montelukast was already started by pulmonologist for treatment of asthma and was continued by us. Patient was posted for right eye plaque removal with double layered amniotic membrane transplantation with fibrin glue with supratarsal injection triamcinolone. This is the post-operative day 1 photograph showing the results with prompt intervention. The upper palpebral cobblestone were resolved and cornea showed significant rarefication of opacification in pupillary area, thereby allowing marked improvement in visual acuity from counting finger near face at presentation to 6/36 unaided after 6 months. Along with frequent cold water lavage, cold compresses over eyelid and maintenance of proper eyelid hygiene, a patient has been continued on both eyes cromolyn sodium 4% eye drops 4 times a day, carboxymethyl cellulose eye drops 6 times a day, and tacrolimus eye ointment at bedtime. Judiciously used conventional treatments lower the medication burden while preserving the limbal stem cells and preventing further severe complications. Supratarsal corticosteroid injections, surgical debridement, and amniotic barrier helps to create a favorable environment for corneal epithelial healing. Surgical debridement involves the removal of the dense plaque tissue composed of cytotoxic eosinophil granule major basic proteins from the local environment and removal of which causes hasten the healing and reepithelialization process. Corticosteroid therapy generally relies on general suppression of local immune system and keeping it pulsed, and to minimum it prevents undesirable adverse effect. Rather than exposing the already suffering young children to the harmful and toxic effect of systemic immunosuppressive drugs, we must understand the prudent application of the fundamental understanding of disease pathophysiology. As this is a single patient case report, it would make a bigger influence to carry out a larger study for adding weightage to the subject. Thank you.
What about the glaucoma aspect? You have not spoken. You are giving prednisolone eye drops.
Yes, ma'am.
One
Prednisolone eye drops was given only until the operative procedure was done. It was kept on pulse therapy only. Patient presented to us after was unsuccessfully treated by multiple centers. We started on cromolyn sodium. As we know, it takes approximately 2 weeks for the medication to affect.
No, I am not questioning why you have given. That is
Yes,
fine.
post-operatively, the
Did
topical
you-
steroids were discontinued post-operatively.
Okay.
So,
Even with the amniotic membrane.
low potent steroid were given. Yes, ma'am.
That's you should say.
I think.
And when you were giving prednisolone, predfort or whatever, you were adding any anti-glaucoma medications
No,
to
ma'am.
prevent, and no mention whether the IOP was very high, because already the child would have been treated and he would have come to you, no, with the.
Yes, ma'am.
So no mention about the disc changes, no mention about the IOP. We assume it was all right.
Ma'am, in the right eye, there was a central plaque involving the visual axis. So, fundus examination was not possible. B scan was done, which was unremarkable for cupping or anything.
Okay. Other eye was all right.
Other eye was normal, ma'am. Anterior segment findings were there, but posterior segment, the disc was normal.
So the
in other eye.
pressure could not be measured.
Could not be measured.
So you removed the plaque and you did the amniotic.
Yes, ma'am. Removal of plaque was done, and double layer amniotic membrane transplantation was done, along with supratarsal triamcinolone.
So for the double layered, how did you do? How the first layer was how much and the second layer was how much?
Sorry, ma'am.
So the double layer amniotic, can you just describe how did you do that double layer?
The procedure was not done by me. It was done by the consultant. I'm a resident in the.
So you
unit.
don't know how much it was done. Usually
The
they
thickness
remove the
is-
plaque and then they give the small amniotic. Was it sutured or it was used fibrin glue?
Fibrin glue was used, ma'am, in the both the layers, and anchoring sutures were also taken for
Taken at the
yes,
limbus, right? That is what I wanted
yes,
you
ma'am.
to answer. Thank you.
Okay, thank you.
Yes, yes. Yeah, please come. Yeah, that is what I wanted to ask. Please answer in the mic. That is what I wanted him to answer. Thank you.
Thank you, ma'am.
It's all right. Yes.